Varona, thank you so much for joining us. Well, a revolutionary new procedure is showing promising results for patients at risk for lung cancer. This robotic bronchoscope has made its way exclusively to the Hospital of Central Connecticut. And I'm so happy to be joined by Dr. Stefan Kachala. He is a thoracic surgeon at the Hartford Healthcare Cancer Institute at the Hospital of Central Connecticut. So good to see you again.
Good to see you too, Tina. Pleasure to be here.
Absolutely. So tell us about this new procedure that is really making it easier to detect lung cancer in a minimally invasive way.
Yes, so this device created by Auris Health is essentially, as you said, a robotic bronchoscope. It allows us to diagnose the early stage lesions for patients in order to get them to therapy much quicker in a safe fashion, excellent patient experience as well.
Yeah, absolutely. So let's talk about the conventional method where you would use a needle biopsy versus this. Let's talk about the difference between the two.
Right, so typically if a patient has a nodule that is suspicious for cancer on their CT scan of the chest, we would, doctors such as pulmonologists or thoracic surgeons like myself would refer them to the radiologist, where using CT guidance, they would place a needle into the lesion. As you can imagine, placing a needle into the lung may allow some air to escape, much like a balloon. So the nature of why a bronchoscopic biopsy may be a better experience for the patient is that the needle is already inside the balloon, hence there's a lower risk of lung collapse. Very excited about this potential.
Absolutely. So the precision and the accuracy, and I want to talk about that because that's critical. And I want to make sure that we stress that this is robotic assisted. So the technology is only as good as the surgeon behind the control, and it's a gaming device that you would use.
Right.
So tell us about the precision and the accuracy of this and how it works.
So in a traditional bronchoscope, the user is actually manipulating it with his thumb and his hand, and small movements translate to large movements on the end of the bronchoscope. Because you're using the computer to help maneuver, and then I'm actually having minute adjustments via the gaming controller resembling that of like an Xbox or PlayStation, I can simply move the bronchoscope with a flick of my wrist only a millimeter at a time, and then it stays in that position. So, for example, the machine itself, creating a map of the patient's chest to get to that lesion, creates a sort of GPS direction, which I follow using my own visual cues, understanding the patient's anatomy. It gets me close to that lesion, and once close, then I can use the biopsy tools at my disposal to obtain tissue. Again, the bronchoscope does not change its position even when I'm not controlling it.
Now, I want to talk about how patients arrive to you, because we often hear with patients with lung cancer, the symptoms don't present until it's at an increased stage.
Yes.
How are patients getting to you to biopsy these potential cancerous lesions?
So the bulk of my patients are typically people who have been smoking for a while, and their primary care doctors or their pulmonologists are concerned about the possibility of lung cancer. So patients who are over the age of 55, been smoking for more than 30 years, are typically eligible for a screening CT scan of the chest. Any abnormal findings, usually their primary doctor will discuss with them, and if there's lesions that need to be evaluated, they come to my office for referral. And then we discuss what is the most appropriate way of obtaining that tissue. And I'm really grateful that because of the low risk, mainly due to anesthesia, they were able to offer this to a significant number, if not all of our patients at this time.
Let's talk about the patients. You mentioned 20% of your patients that come to you are non-smokers, and that's always the scary part, is that there are patients out there with lung cancer who have never smoked a day in their life.
Right.
How are those patients getting to you?
So, very interesting question. Typically, it's due to an incidental finding, whether or not they're maybe having shoulder surgery in the future, and imaging suggests the presence of a nodule in their lung, or perhaps they had some sort of abdominal or gynecologic procedure upcoming, and the CT scans that their doctor obtained show that there's some abnormal findings on that lung tissue. That's the most typical way that patients come to me who haven't been former smokers.
Dr. Kachala, I want to talk about patients that come to you that they've been smoking for many years. This is more than just about this new robotic technology. This is about the broader scope in terms of the multidisciplinary approach at the Hartford Healthcare Cancer Institute. So take us through that whole approach to each specific patient.
Right. I think starting from the beginning, if you are smoking, we at Hartford Healthcare are here for you. Everyone from your primary care doctor, lung doctor, our nurse navigators, and of course all of us at the Cancer Institute. We have many, different options at your disposal to help you quit smoking and decrease that risk of ever developing a lung nodule or lung cancer. If you do have a lung nodule or suspicious that you may have one, we strongly urge you to reach out to your primary care doctor or pulmonologist again to obtain that screening CT scan study that's covered by many insurances nowadays. Finally, once we have those imaging reports, that's the next step. That's where I'm only one part of a larger team to really kind of help optimize your health and get you back on track where this is just going to become a distant memory rather than something that you're suffering from for a long time. Absolutely.
And a distant memory, as you just mentioned, I wish COVID was a distant memory,
Yes.
but I do want to talk about that because we're learning so much more and it's
Yes.
ever changing in terms of how COVID affects the body. COVID, obviously, big impact on the lungs. Any correlation there between, and I'm sure it's probably too premature to say at this point, but in terms of cancer or lesions that can develop from somebody recovered from COVID and how it affects the lungs, what do we know at this point?
So we know that COVID engenders a high degree of inflammation, not only to the lungs, but many different organs of the body. And clearly, those of us who look and treat for lung cancer, we're worried about these patients in terms of what are their risks in the future for ever developing these lesions. I think for those patients who are fortunate to be able to recover from this devastating disease, we are going to want to monitor them ongoing forward because we're still learning of what the after effects are to patients' lungs after this. There are some patients who, despite overcoming the virus, have never had any manifestation from a lung perspective. And then there's those other patients, many of whom were otherwise healthy and never smokers, now have these after effects in lungs of the scar tissue and heavy damage that the COVID-19 is able to wrought in them. So we're still learning, and honestly, if you have developed this, be in contact with your physician because this is something that needs to be monitored over time.
When you talk about inflammation and COVID, can there be on scans, can that appear to look like a lesion when you see that inflammation, or is there a clear distinction that it is not a lesion? Can it look as though it is a lesion?
I think the easiest answer is to say yes, because if you gave a radiologist a simple CT scan showing some findings that were in a discrete fashion, small, we call them ground glass abnormalities, without the background understanding that COVID was there, it could resemble an early lung cancer under a ground glass opacity. Typically, when radiologists are seeing these findings on CT scans, though, we have the background understanding that they're there with the symptoms of COVID-19. We're doing the COVID-19 testing, so we have that as a background. In isolation, though, the findings associated with COVID-19 tend to be more diffuse, involving large areas of the lung without discrete solid lesions like we typically see in lung cancer.
Right.
So that's the ultimate difference.
And with this robotic bronchoscope, would that be something very useful in terms of determining, would it be easier to see that this is clearly inflammation and not
So in the
lesion?
absence of ongoing infection with COVID-19, I think this would be a safe technology to bear. But one thing that we know now is that procedures, especially general anesthesia in patients who have active COVID-19 infection, can result in additional complications and a tougher, more complicated course in recovering from that disease. So we tend to not want to perform them unless absolutely necessary. Now, in those patients who are not aware that they have COVID-19 infection, we are actively testing before any proposed procedures. So that would hopefully help identify them. But coming back to your original question, yes, if there is evidence of inflammation in a lesion that we're suspicious of a lung cancer, we will see that inflammation but not see lung cancer cells. So that would, again, further encourage us to go down that area of evaluation.
And of course, every patient is different, and this is just another diagnostic tool in the toolbox to use in terms of identifying patients at risk for potential lung cancer. When would you use the needle biopsy versus this robotic bronchoscope?
So in a patient who has a very peripheral small lesion in an area that would be easily accessed perhaps by a needle biopsy, those are truly lesions that are appropriate for that approach. But a large majority of lesions now are far more central, and this is a technology that would have a less risk of lung collapse than the traditional approach of a needle biopsy. But what we're seeing more and more is that the reason why we say that the bronchoscope can help us determine earlier stage lung cancers, and even those that don't have a solid component. Again, just a slightly higher density, we call them ground glass opacities, typically associated with, we call them minimally invasive cancers, that perhaps the most appropriate thing would be to resect those lesions. Well, obtaining the biopsy is only one aspect of it, but we can also mark those lesions and remove them, even though you can never feel that there was any difference in that lung tissue. So, not to say that the traditional needle biopsy with CT guidance doesn't have a role. It certainly does, but given the improved safety profile of this device and the excellent patient experience, and then we can also diagnose and stage the cancer in the same setting, there's more that we can bring to bear. But then also, this is just another tool in our kind of toolbox that we can bring to bear in treating patients' lung cancer as well.
Well, and I think too, for patients you talk about the patient experience, and a patient who is coming in who is trying to find out and you're diagnosing to see if in fact they do have lung cancer, that's a scary time.
Yes.
And then to have to go through something and then wait for the results, at least they're getting everything at one time, even proper staging and confirmation. It makes it a little bit easier because at least you can identify it, there is no waiting, but then you can really start that treatment plan.
Right. Sometimes, because the pathologists are just outside the room, when I obtain that tissue, they can be evaluating within minutes. And then sometimes I've even called the oncologist and gotten them those referrals so that by the time they wake up, we've been able to establish, next steps for them already.
Well, Dr. Kachala, this is wonderful to have this robotic technology at the Hospital of Central Connecticut and you leading the way with it. So we appreciate the time and continued success in terms of identifying these cancers and helping so many patients. So we appreciate it.
Tina, thank you for the opportunity to be here. It was a pleasure.
You bet. And of course, thank you as always for watching. I'm Hartford Healthcare's Tina Varona. We'll see you soon and be well.